Hi, you're listening to the Doctor's Business Management Show. Today's physicians, dentists, office managers, and healthcare administrators face new challenges every day. Whether you're in private practice, employed by a hospital, or corporate business, the financial matters, tax planning, employee management, and healthcare compliance have become monumental tasks and concerns. The Doctor's Business Management Show's objective is to provide you with information that will help you manage and lead your business so that you can better care for your patients and for your family. The insight of the industry experts on this show will bring practical, indispensable information and sound practice management tips and techniques for improving your bottom line and to help you grow your practice. We're here to help you practice on purpose, at work, at home, and at play. Today's show is being sponsored by Vanderlick Mulder DeVries & Elders, a CPA firm dedicated to improving your bottom line. MD Management Group, helping doctors mind their own business. And by the National Society of Certified Healthcare Business Consultants, educating and certifying professional consultants in the business of healthcare. I'm Mike DeVries, and I'm here to help you mind your own business. Well, hello and welcome back to another episode of the Doctor's Business Management Show. I'm Mike DeVries, the host of this podcast, and today's episode is the 11th episode in our first year series. If this is the first time you're listening to the show, I welcome you here and would encourage you to go back and listen to our previous shows, which has some great information. You can find the show in iTunes. I found it best by searching in the iTunes store using my name in the search box, Michael L. DeVries. Or you can find the episodes along with the show notes on my website at www.mikeldevries.com. That's MIKELDEVRIES.com. If you're a regular listener here, thank you. We do appreciate you listening in, and we appreciate your kind feedback on iTunes, which helps us in promoting our show. So be sure to do that. Thank you very much. Well, let's get started. Today, our show is going to be a little different. The remainder of the show is going to be a recording of a webinar that I did with Nate Moore, a data consultant out of Utah and who is a fellow member of the National Society of Certified Healthcare Business Consultants. Nate and I met up at the Society's annual meeting this year, which was held in Las Vegas, when Nate presented a session on how to gather and use practice management data. In our office, Ben Lane and I have been working on obtaining data from our clients' offices with the goal of helping them manage their practice even better. We currently do this for several dental clients, but the process we use is a little different. Nate presented a way to do this that really intrigued me, and so I called Nate and spent some time with him. Out of our discussions came the idea of doing the webinar that you're about to hear. Now, if you want to get the best experience, I'd suggest that you go to our website, that's www.mikeldevries.com, and watch the webinar as well, so that you can see Nate's examples of using your data within your practice to help you manage your practice better. But if you're traveling in the car or maybe not near the computer right now, what you're about to hear should still be helpful. So sit back and listen. Here you go. Here's the webinar. Hi, this is Mike DeVries. Welcome to the webinar. We're at from the offices of Vanderlick Mulder DeVries & Elders, the CPA firm here in Granville. Today on the webinar, I have with me Nate Moore. Nate is a business intelligence data gathering guru, call him. Nate and I met at the National Society of Certified Healthcare Business Consultants, and he is going to present some information on helping you look at your practice differently through the eyes of data and data gathering, and ways in which we can do that and build some sustainable reports for your practice to help you manage your practice. Nate, thanks so much for coming on board.
Mike, thanks for inviting me. I'm looking forward to it.
Yes, so Nate, we met in Las Vegas recently again, and you did a presentation there on this, and I thought it would really be good to share this with my clients.
So thanks for doing that. I'll turn it over to you.
Great, let's get started. There we go. Again, I'm Nate Moore, and what I want to talk about today is how to build sustainable, customized reports in your practice. If you're a little frustrated with the canned reports coming out of your practice management system or your EHR, you're in the right place. I want to talk about how to use the data in your practice. It's just the raw material of knowledge. It doesn't mean anything, it doesn't do anything unless we can present it the way you need to see it, when you need to see it, how you need to see it, so you can act on the data that's trapped, if you will, in your practice management system and your EHR. The way I like to think of data is in data sets. What I mean by that is just a group of data. If you picture a table that has all your charge information in it, there might be a row for every CPT code, and each column would tell you about that CPT code. Who is the patient? Who's the provider? Who referred them? What's the CPT code modifier? What's the diagnosis code? Primary insurance, place of service, all that kind of stuff. And you gather those data sets around different topics, whether it's adjustments or contracting or lag days or whatever. And you can use one data set to feed dozens and dozens of reports. For example, if you had an appointments data set, here are some of the things you might see in that appointments data set. And that one appointments data set could tell you how many patients did we see last week, how many are scheduled next week, talk to me about no-shows, how long does it take to get in to see me. There's all kinds of reports that you can generate based on one data set. Once you have the data set, there's kind of three models or three ways to act on that data and report that we're going to talk about today. The first one is the traditional way. You run some kind of canned report and you export that to Excel, and then you have to clean it up and get all the headings and the footers and the weird column and all that kind of stuff out of it, and then you can analyze it. And that's one way to do it, and that's probably the easiest way. That's the way you typically get started. The problem is, if you want to run that report again next month, you've got to dump it to Excel again, clean it up, and do all the cleanup before you can do the analysis, before you can see have things changed in the past month.
That's the way I've always done it, Nate. And seeing what you have done and what you're going to explain next is really powerful.
Yeah, the challenge is it just takes too dang long, Mike. I mean, if you want to see, how am I doing this month and how am I doing next month? I mean, every month you spend more time running reports and not enough time acting on them.
Amen.
So the game is that most practice management systems and EHRs store their data in a relational database program called SQL Server that Microsoft makes. And the idea is that SQL Server knows all the data. It knows it knows all the information about your practice. And Microsoft made SQL Server, Microsoft made Excel, and they talk. And what you can do is say, hey, Excel, every time you open, go out and get fresh data from SQL Server. And it might take Excel another 30 seconds to open. But when it does, you're looking at cleaned, organized information the same way you left it last month or last week or yesterday, only with new data. And that whole automatically refreshing thing is the big time saver that Mike and I were talking about at the meeting in Las Vegas. So that's door number two. That's the second model. The third model is to move away from Excel over here in the circle. And you're still connected to SQL Server. But if you own SQL Server, you also own free with almost every version of SQL Server, a program called SQL Server Reporting Services. The acronym, or they abbreviate it, SSRS. What SSRS will do is two things for you. Number one, it can create web pages for you on like an internal intranet where you can go and run dashboards and that kind of thing. The second thing it can do for you is it can send you scheduled emails. Hey, the 15th of every month, I want to see this. Every Monday at 7:30, I want to see that. Every day at 7 a.m., I want to see this. And it can push information to you as opposed to having to go run a report, dump it to Excel, and do it the hard way. It can push information not just to you, but to your providers or to your managers or to whoever needs to see that data. And I want to show you a bunch of examples of that as we go through the presentation today. Before we get too excited about SQL Server, one of the cautions you need to understand is that SQL Server is running your, what they call production data, or your day-to-day operations. People are entering H&Ps and recording EOBs and entering claims and all that kind of stuff using that SQL Server database. And if you have more than a few providers, you run the risk that you're going to slow down your system by running all these clever new reports. So what you might think about doing is using what they call either a report server or a data warehouse, where what you do is you pull the information off that's critical to what you're going to report on, a data set, let's say, around charges or appointments or payments or whatever, and you pull that off into a separate database, maybe even a separate SQL Server installation, so that you can run reports all day long without slowing down your practice. That's the one thing we don't want to do, is get better reports but slow down the practice. There are several Excel tools you might use as you go through this. If you're not familiar with pivot tables, boy, they're the best thing since sliced bread. If you're an Excel user and you've got a bunch of data, they're a great way to analyze and trend and slice and dice an awful lot of data.
My staff gives me grief because every time I say something about the data that we have, I'll go, oh, well, let's put that in a pivot table and then we can really extrapolate it and see it. And they're like, oh no, here comes Mike and his pivot tables again. You know?
Mike's drinking the Kool-Aid on pivot table. Once you've seen your data in a pivot table, you'll be drinking the Kool-Aid too, and just say, hey,
exactly right. Yeah.
It's the way to analyze data, and I'll show you some examples of that. We're not going to go through the nuts and bolts and click here, click there of how to use a pivot table today, but I want to show you some of the end results, the why to do this stuff, not necessarily the click by click how to use some of this stuff. That's the Excel side. On the SQL Server Reporting Services side, again, it's web pages, it's emails, and it's all automatic. And that's the key to models 2 and 3, is it's the automating of the process, so we don't spend any time looking for reports. We spend all of our time acting on reports. That's the game. Some examples of what you might do with these different tools. This is a dashboard from a group that wanted some custom information. They said, we want to look at the current month and the current 6 months, last 6 months, and the change and the variance, the year to date, the prior year to date, and we want to look at around RVUs and receipts, and we want it exactly like this. And that's the advantage of SQL Server Reporting Services. You can gather a data set around receipts, around RVUs, and once you know that, you can use SQL Server Reporting Services to get a pretty customized. You notice decreases are in red, increases are in green. You can make this thing do pretty much exactly what you want, and then it's available in anytime you want on a web page, or this dashboard that has this procedure trends with RVUs and things like that, new patient trends, who's sending us patients, this month versus our last month versus the last 6 months, when was the last new patient, how about these groups of referring physicians, what do they look like in the prior 6 months, are they up or down? All of this stuff is available anytime you want on a dashboard, or for this practice, it comes 15th of every month. And then rather than run this for every single provider and then email it to them or whatever, you can have that all automated and say, hey, I'm going to send Mike his copy, I'm going to send Nate his copy, I'm going to send everybody else their copy, and automate the whole thing so everybody knows where we are at any given time. Again, SQL Server Reporting Services, that's the name of the tool, and it's really your friend if you want to automate and push information to people. Let me throw you another example. This is in an Excel table, and what we've done is we've gone and grabbed all the outstanding AR that's owed by patients. The way this practice runs it is they have their insurance AR from payers is in one department, and then the balance due from patients is another department. And this is what the patient side of the ledger does. And what they've done is they've assigned letters of the alphabet to different people. And now what this spreadsheet does is we've taught the data warehouse who gets which letter in the alphabet, so they can slice and dice the receivables data. How many claims does Sally have, and how many claims does Michelle have, and that kind of thing, by time period and by aging and all that kind of stuff. So rather than run some nasty long report out of your PM system and try to figure out who to call next, this in Excel automates the whole process. You can sort and get the biggest claims, the oldest claims, all the Blue Cross claims, whatever you want to see, and it's going to simplify it for you and make your life a lot easier when you try to follow up on AR.
To be able to then track the actual results of that too, right, Nate? By the person working that, so you can kind of see some report that would show how much Sally's doing versus Jamie, and
it's all about accountability. Exactly. Right. And part of it, Mike, is it's one thing to keep score, and it's a whole nother thing for me to know that you're keeping score. You know what I mean?
Right.
That accountability and that reporting back thing, it just makes a big difference in performance if we're keeping score and everybody knows what the score is.
Right.
This is a little bit more custom. What this group said was, hey, we want all the unpaid secondary claims. Gather those all up where we've sent something off, a claim off to them, either electronically or otherwise, more than 30 days ago, and we're not paid yet. And so rather than look for problems or wait for things to pop up, what this report does is automatically grabs claims that meet that criteria, and here's a ticket number, here's the account number, here's the balance that's due, here's the date it was filed, and you can immediately sort and figure out, this is what I'm going to work on next, this is what I'm going to work on next. And what we're trying to do is give the staff tools to do the right thing the first time. What's next? What should I work on next? And do it right the first time. And if we can do that, what I found is you can do more work with less staff because we're giving them the tools to do a better job. You can add providers without adding staff, and in today's economy, that's a big deal.
Yep.
Same idea with this one. What we're grabbing now is I want all the claims in the past 13 months that zero paid. And so we got some kind of denial. We want to follow up. The key to this one is, see that pink column over to the far left? The idea of the pink column is, what we're saying is, hey, we are going to teach that data warehouse what the denial appeal deadline is for all the major payer groups. So if we've got a $500 claim that we don't, we still got maybe 9 months to appeal, we're not as worried about that. But if if I've got a $5,000 claim that doesn't have 9 months to appeal, I'm still $5,000, but I may not work on that one either. I may work on the $400 claim where the appeal's up tomorrow or next week. And by prioritizing and saying, here's when the deadline is, it just makes me so much more efficient when I'm trying to decide what do I work on next, because things don't fall through the cracks, the deadline passes and we lose, that kind of thing. This is a report I did for a group that has physical therapy. And they went to some kind of physical therapy meeting, an annual conference kind of thing, and came back with the idea that, hey, for their practice, for their situation, for their cost structure, all that, physical therapy visits had to have at least 1.5 work RVUs to keep the lights on, to break even, to make ends meet, if you will. And so what this report does is it runs every morning at 7 a.m. and it says, hey, show me all the PT visits that happened yesterday that didn't have at least 1.5 RVUs on them. I want to know who the patient was. I want to know who the therapist was. I want to know the data service. What were the charges? What was the work RVU? And this email goes to the practice manager, and it also goes to the director of PT, so that the therapists get the feedback immediately, not 6 months later or a year later or whatever. They get the feedback immediately, said, hey, here are visits yesterday. We got to make sure we're coding these appropriately to keep the lights on in PT.
That's great.
And it's that same idea we talked about, Mike. The accountability, tell me right now, real time, when I still have a chance to do something about it. Don't tell me, when the water's, so far under the bridge that it's, it's in the Atlantic now or whatever. I mean, it's way too far gone to do anything.
Yeah, or worse yet, nobody ever looks at it, period. They just
and we wonder why we're not profitable.
Wonder why we're not, or that we could be more profitable,
Or we got 6 therapists doing it right, and one therapist, this is the way we've always done it, or wasn't trained or didn't know, and we never knew that. And now if we implement, the other thing that's important here, Mike, is if we implement a program, we say, all right, we're going to do it like this from now on, and we got this training, we're going to do it like this. We need a way to keep score. We need a way to make sure that the changes stick. And that, a daily email is a great way to do that.
You bet.
This is just a simple one that says, hey, you know what? We're going to track prior authorizations. I talked to a group in Florida not too long ago that said, hey, can you help us figure out if we've got prior authorizations for upcoming claims? Because what we pay somebody every day to look at our upcoming appointments and go look and see if they've got pre-auth. I'm like, well, does your system know that there's upcoming appointments? Well, yeah. Do you put your pre-auths in the system? Well, yeah. And I said, well, then let's let the system do it. Tell me who, let's go grab all the open appointments where we know that, procedure type appointments. We know we're going to need a pre-auth, and let's go look for it. And let's highlight the ones that don't have it, and let's work on those. Let's not look them up every day and make sure we've got them. Let's just look for the ones we need. This was something we did for a group some time ago, and what they wanted to know was how they centralized all their coding and their entering charges and that kind of thing, and they wanted to know how productive is this staff. So what we did is we said, all right, we're just going to go count the number of CPT codes entered by who entered them for a month, and let's see who's entering more claims. And everybody's claims are harder, and all that story, Mike. But
right,
the idea is, hey, we're going to keep score. We can keep track. We can see, are we getting better or worse? Are we getting more efficient, less efficient? That kind of thing. And just by doing that, we can, again, we're trying to make the staff more efficient so we can hire more providers without having to have a similar increase in staff.
This wouldn't track the hours, obviously, because that's not necessarily in the system, right?
Correct.
but we could lay that over, take payroll reports and say, look at how many claims, or in this case, you're doing each charge entry. Is that what this
Yeah,
is?
it's every CPT code. You get one for every CPT code, right?
Right. So if you take that, you could say, well, here's how many CPT codes they're doing per hour.
Exactly. And if we paid that top person on the list, for, let's say 100 hours, and the next person down, B. Martin, got 7,200 done in 10 hours, the top one's not necessarily leading the league because we've got, it's taken way too long to do all those claims. And what we need to do is, grab both pieces of information and present the complete picture to management, if you will.
Right. It also, this in a real neat way shows the, who's working when. So you can kind of see, well, on November 13th, we had all but one person working, and on, 3 days ago, we only had 2 billers working.
And the other thing, it's a great point, Mike, because the other thing you can do is you can throw scheduling around this and say, hey, there's this big bolus of claims coming down on Wednesdays or whatever, so we're going to staff accordingly. We're not going to, our shifts may not be 8 to 5 every day. We may work, half day Mondays and longer on Wednesdays because of the way our claims flow through. And we stop playing solitaire on Monday and we work harder on Wednesday. You know what I mean?
Right. That's a great idea. This is great. Yeah.
And again, 30,000 foot level, you may not have physical therapy, or you may not have a central billing office, or you may not have some of the other examples that we're talking about. But the underlying point is, hey, we can grab data and act on it and change the way we run our practice.
Hey, how about this, Nate? I've got practices that are using billing companies to do their billing, but they do it by going in on their particular system. So now you can track and see when the billing company is actually working on your information and say, you know what, why are we having all these gaps? And no wonder we're not getting some claims done.
You make a good point, Mike. Typically, every system's different. That's the first thing for sure. Every PM system is different. But typically, they'll store the date and time and who entered these changes, because they've got HIPAA regulations and stuff like that. So
Right.
You could do things like that and go grab that and say, well, it's all being done between midnight and 4 a.m. in India or whatever, and you could at least know when it was getting done. Or you can, if it was really important to you, you could get a daily email that said, how many hours, what was start and stop time yesterday, or how many claims got billed yesterday, whatever. We could automate that and push that to you. This is a pivot table. This is so you can slice and dice and analyze in Excel. But we could automate some of that information and push it to you via email. So you could say, hey, it's been 3 days since anybody was even logged into my system. What's up with that?
Right.
That kind of thing.
Right.
Same kind of approach here. What this practice did is they said, we're a little frustrated with getting collections from patients, outstanding patient balances, big balances. And so what they did is they said, we're going to try something. We're going to have a couple of our collection staff make outbound collection calls. We're going to give them a list of people to call, and they're going to call, and we're going to see how effective that program is. So the game was, and the reason I included this report in the slides was they had to change their workflow to track this information. What they had to do was every time they made an outbound call, they went into the practice management system and put in a dummy line in the bill. The dummy line doesn't show up on a patient statement, doesn't show up on a CMS 1500 form, but it does show up so I can track it. And what that dummy line tells me is, okay, here's the day that they called and who they called. So now that I know that, I can say, okay, I called Mike on September 1st. How many payments did I get between September 1st and September 20th? Am I a good outbound collection call person? Or when Mike does the call, is he better at it? And, he's collecting, way more money, and I ought to have Nate be doing, data entry, and Mike ought to be making the calls, or vice versa, because I can tell who's more effective making calls. Again, what you do is you might change your workflow to gather more information that you need to make the decision, but then you can say, all right, here are the patients we want to call. These patients are more likely to respond to an outbound collection call, and if we're going to do an outbound collection call, I want Mary to do it, or I want John to do it, or because they're the best one at actually collecting. And again, I know the date of that call, so I can look for payments the next 20 days, and I can, evaluate the success of my program, right?
Right. Nate, you make a good point earlier on, and now you just said it again. It's like, if you want to collect something, the data has to be put into the system. So if we're thinking about that, and this was kind of a unique way, you said, well, it wasn't necessarily in there, so we created a dummy account. I think of a practice, and some of my practices right now, who are looking at adding some providers. And one of the things I said to them is, well, why don't we track how many times you get a phone call into the practice that you're turning them away because you just don't have anybody to, schedule them with. I mean, it's like, no, we're not accepting any new providers. Well, if you're getting 10 of those a day, let's extrapolate that, and how long would it take to fill a provider's schedule? And so we were at the meeting last week, and I asked the office manager, well, yeah, she's tracking it, but she's doing it like on a piece of paper, and then she's got to create a report, and we have no reporting process. If we did it this way, we would have a neat report that could be sent out. How many patients called today or the last week that we weren't able to schedule because we didn't have a provider?
Yeah, absolutely. And then you track it, you trend it, and then you can say, all right, here's the kind of provider we need. We're an orthopedic group. Well, we really need another hand guy, or no, we need a sport guy, or whatever, because that's the kind of provider that's being requested. The other thing I've done, I don't have a slide for it in this deck, but what I've done there was a group that used to pay somebody to come in 45 minutes early every day and try to make a dummy appointment for Mickey Mouse with all 30 providers. And then they wanted, what if I'm a new patient? What if I'm an established patient, based on their templates, And so they'd pay somebody to come in every morning and keep track of how long it took to get in to see all their providers. And I'm like, well, the system knows all that stuff. Let's just write code. Let's store it automatically, and then let's trend it over time and see if it's getting better or worse. Right. And you can do things like that to say, hey, you know what? It used to take 12 days to get in on average. Now we're up to 23. We're losing patients because they can't get in to see this type of specialty or this type of provider or this location. You know where I'm going.
Right. No, that's great.
What else do we have in here? Oh, this is just a simple thing from the way this group uses centricity, and they've got a bunch of providers, and this spreadsheet goes on for a couple of pages, and they just want to know who's where. They have a couple of main clinic locations, and they have some surgical locations and an ASC, and then they've got outlying clinic locations. Like, where is everybody? And so what we did is we wrote the code to keep track of it. And then this spreadsheet, that yellow box up the top, you just type in the date of the Monday of the week you want to see. And when you type that date in, it'll show you where everybody is Monday through Friday, AM, PM for that week. And it makes it real easy to keep track of who's where. Then what you do is you marry that with the clinical schedule, and you say, okay, if the provider always gets a nurse when they're in the office, we want to make sure when they're in the office they get a nurse. But on the other hand, when they're in the OR, we need that nurse assigned someplace so we're not, wasting resources. And you can go back and forth like that, which is basic information coming out of your PM system. A couple of more appointment ideas. What this group does, this is a group in Texas, and what they try to do is they say, all right, we're going to teach that report server, that data warehouse, a bunch of things to look for. When this goes wrong, when this goes wrong, when this goes wrong with an appointment, we want to know about it. So every morning at 7:30, what happens is the data warehouse runs all these tests, and it captures, hey, this is a new patient, they're scheduled with, or a new problem, they're scheduled with a PA, or this is a patient that hasn't made their deposit for this type of appointment and they're coming in tomorrow, or this is a patient that's on hold or in collections, or any other problem they want to find. And rather than look through their schedule for problems, you automate all that. And you get an email in the morning that says, hey, here's all the upcoming appointments for problems. You don't have to worry about it or look for any of them. You just have to solve these. And it's a great way for them to be a lot more efficient with their scheduling process. And again, you may not care about those issues, Mike. You may care about a dozen other issues. And the whole point is it's custom. You tell the data warehouse what you want to look for. Here are the appointments that worry me. And let's get a report every morning and keep track of them and solve it.
I do this with some dental clients. We have a way to gather information out of their system. We present them with what I call a morning meeting report. And it's kind of this in a way. It's every day you would get this report that shows you which patients are coming in today. Well, can you imagine doing that with a doctor group, a medical group, where they meet early in the morning and say, well, these are the patients that are coming in today. What kind of issues do we have with some of these patients? What are we, what's unique about today? And solve it right there together while you're all sitting there in the morning before you even start working. Hey, remember, we got to ask Mike DeVries about this particular thing, or we don't have these forms in this, file or whatever. We got to make sure we take care of that information, Great way to do that. Or solve for appointment issues,
And I've done that with clinical information as well, to tell nurses, hey, you know what? Here she's coming in next week, and they don't have these labs, or they don't have these documents signed, or they don't have, this this required form, or whatever the issue is, and we solve it before the patient gets there. That kind of thing.
Right.
This is just a chart that comes out. There's a practice I help that has 3 main locations, each about half an hour apart. So what they do is they grab the types of patients that are scheduled to come in on every day by these, you'll see there's half-hour increments. And what they can see is they know that new patients, the purple on this chart, are going to take longer. And so what they'll do is they'll chart this, and if they say, hey, we've only got 4 places for new patients in the entire clinic, and we got 5 coming in tomorrow at 10, then what they'll do is they may move somebody, they may move staff, they may call Nate and say, hey, Nate, can you come in early? Or hey, Mike, can you come in late? Or whatever. They can see what tomorrow looks like by the type of patients that are coming in, and then schedule accordingly. And again, they had to add information to their system to bucket or categorize which patients are brand new and which ones have signed in on the portal, and all we need to do is say hi to them, which ones were here last week, and everything's up to date, all that kind of stuff. But you put that information in the system, and you can decide where you're going to be busiest tomorrow and allocate staff accordingly. Similar kind of thing. This is from a group in the Southwest, and what they want to do is look at open appointments for by location. They're obviously orthopedics. If you look at the hip, knee, foot, ankle, and what they're trying to do is say, hey, where are my open appointment slots? So if somebody comes in and says, hey, you know what, it's my elbow and I want to go to this part of town, they can immediately go to this screen and see, okay, here's where my open appointments are. And the other thing they can do is they can throw logic behind the scenes here, Mike, and say, hey, you know what, this guy, Dr. Johnson's brand new, we want to feed Dr. Johnson, or Dr. Lee's a partner, so he gets priority, or Dr. Ping, she gets this because of that. You can put some logic behind to decide who schedulers choose when they have a choice. Does that make sense?
Yes, perfect sense. It's great.
This is a group that these guys are orthopedics too, and they were trying to decide, hey, we're remodeling an office. Do we do 3 X-ray rooms or do we do 4? Problem, in the X-ray room, you got to pay for the machine. Obviously, you got to pay for the X-ray tech, and you got to shield the room as well. So if you can get by with 3 X-ray rooms instead of 4, you save serious dollars. And it's a long-term savings, because even after you buy the machine and shield the room, you're still paying X-ray techs. And if you can use 3 machines instead of 4, you win. So what they did is, again, they changed their workflow. They changed an EHR form to say, if Nate comes in there and Dr. DeVries says, okay, I want you to have an X-ray next time, what the system now requires is, hey, okay, where is Nate's X-ray? Okay, it's left elbow, which views, and they go through all this stuff, so that when Nate shows up for his next appointment, what we can do is say, has Nate been in to see Dr. DeVries lately? No, he hasn't been in since Dr. DeVries ordered the X-ray. Great, we know he wants an X-ray. We know Dr. DeVries likes it without the cast, and Dr. DeVries is backed up 20 minutes, so guess what? We're going to go find Nate in the lobby, take the X-ray, and have Nate all ready to see Dr. DeVries before Dr. DeVries even has an exam room open. And by doing that, we can make the clinic a whole lot more efficient. What they were able to do was do 50% more X-rays, get by with 3 X-ray rooms instead of 4. The docs move faster, the patients move faster, everybody's happy. By adding a little information in the EHR, combining that with the PM that knows who's coming in tomorrow, and giving the X-ray department visibility into what the heck's going on. And again, you may not have an X-ray department. You might care about X-ray. The question is, what would it help your clinical staff to see that you can't see now? Similar idea here. Find all the outstanding charges where I know I charged for it in the EHR, or I ordered it in the EHR. I don't see a charge in PM. I'm not going to go look for those manually. I'm going to go look in the EHR, look for the major things I know I should have got. I'm going to go over to the PM, see if they're billed. If they're not, I'm going to ask why. And I'm going to simplify with an exception report, as opposed to have to look to every single one. A couple of easy ones here for a minute. This is just a simple compliance report that a group in Idaho had to do. And rather than manually do it, we said, hey, the information's in there. Let's just simplify. This is SQL Server Reporting Services. You punch in some dates into this dashboard, it creates the report for you, and you're done, rather than have to manually go out and look for and create reports. This is an example of a report we did for a clinical group. And what they tried to do was they said, hey, we've got pain management docs. And to do pain management, there's all kinds of hoops you've got to jump through. So the pill mill thing. So you've got to have a contract, and you've got to have a urine drug screen, and you've got to have all these other things. So what we do is we wrote a dashboard that said, hey, nurses, go punch in the name of your provider, punch in the name or the date range that you want to look at, maybe next week's appointments, and it will show you everybody who's scheduled to come in next week, and anybody who has a blank has an issue, and anybody, see that red circle on 4/4/2013? That's somebody that, hey, that urine drug screen was done too long ago. And so we'll warn them right up front, hey, that needs to be done when the appointment comes in, so that we're prepared, so the patients get better service when they come in. And it just helps them. And remember in the old days when nurses would pull charts and get ready for tomorrow? You don't have to do that anymore, but what you do have to do is grab the information that's in your EHR to make your clinical process a whole lot easier. This is just a report that goes out and says, hey, we've got docs who are in surgery, and anybody who signs out of a surgical location and changes their schedule, what we do is we capture that information and send an email out the next morning to the surgery scheduling people to say, hey, we've got OR time. It's in the orthopedic hospital, or it's in the ASC, or it's in, over here across town at this hospital, or whatever. We're going to go grab that information, and we're going to tell our surgery scheduling people and other providers so we don't waste our OR time. So we can use it, and that keeps our utilization up, it keeps the hospital happy, and it keeps the revenues up as well if we don't waste OR time.
Can we also capture that information to make sure that the billing information is being put in?
Sure.
I mean,
sure, we can take that back and say, hey,
these are all the ORs, but we don't have it all in there yet. It's not been involved.
Mike was in, the Southtown Surgery Center today, or yesterday, or 3 days ago, or whatever, and I don't see charges yet. Okay, is there a documentation issue from Mike's side, or did we not get something passed over from the ASC, or you can use that to track billing as well. It's a great suggestion. This is from a derm group, and so what they've got is they said, hey, acne is one thing, melanoma is another. What they wanted to do was say, give us all of the patients who came in with an appointment reason of melanoma. And we said, hey, if that appointment either got canceled or there was a no-show and there wasn't a future appointment, we want to know about it. This isn't a revenue issue here, Mike. This is all about patient quality. Man, these folks got melanoma. Somebody's got to do something. So we grab this and say, okay, here's all the patients that didn't show up or canceled and didn't reschedule or whatever. Somebody needs to get a hold of these, have a nurse or a provider call them and say, hey, if you don't see us, that's fine, but you need to see somebody. Because again, it's a patient care issue, not so much as a revenue issue. And again, you may not have any melanoma patients. That's fine. But what kind of patients do you want to capture that no show or cancel? That, again, from a quality standpoint, you want to follow up on and make sure they get care.
I mean, it's interesting because my daughter had some surgery about a month ago. And right after her surgery, I would say that it was like the weekend. It was like a Mother's Day. And we got a call from the doctor. And how's she doing? And can I talk to her? And, just talking to her and so on. We hung up and we went, wow, that was incredible. But, if these practices had this kind of thing available, that doctor could have gotten a call or got a report, said, here's your surgeries from 4 days ago. Here's the telephone numbers. Just make the phone calls.
Exactly.
And you're a star in front of your patient and or the parents,
And nobody had to do anything in terms of research to feed it to that. I mean, the email's automated, right? You just feed it to them.
Right. That'd be great.
Another simple reporting out of EHR. And the reason I included this is they all don't have to have 17 columns and be terrifically fancy and multicolor. All this group wanted to know was, hey, we're primary care. We provide OB. When are these due dates coming up? So we've got an EDC column there, and we'll tell you, here's what the next couple of months look like from a scheduling perspective. And again, it's simple information to pull out of an EHR that made this practice's life easier. Meaningful use. This is an older one. This is stage 1. But if meaningful use is a headache in your practice, what is the issue here? This practice is having trouble getting ethnicity and race and some of those kind of things. They want to make sure that the staff was always getting it. So we said, hey, you know what? There's going to be an email come out. Back to that accountability thing. This one came out twice a day for a while and said in the morning and afternoon, dang it, where is this stuff? If you've got, PQRS or meaningful use or other kinds of issues where you're trying to get staff to comply to meet incentive programs, this is the kind of thing to do. Here's what we're looking for. It didn't happen here. We're keeping score. And here's an email when it doesn't happen.
Or if you're a derm practice and you want to send out notifications or even, notification of patient or of appointments, and I want to send that out a day or two ago, or a day or so before the appointment. I want to send that via email. Well, one of the things you got to do is, again, put the information in. So a lot of practices don't always collect the emails.
Right.
Well, if
right.
you said, you know what, we're going to make sure we want to collect every patient's email so that we can use that down the road or with some notification system or whatever. Well, then the front desk is responsible for gathering that information. And if the patient says, no, I don't want to do that, we put some kind of information in that box so we know we asked.
Yeah, we don't bother you again, right?
Right. And then I go into this system and go, okay, for today, how many people did we see that we didn't collect the information? And you start, again, like you said earlier on, keeping score, just like, let's get that information, because that'd be very helpful for us to keep the number of no-shows down by sending out appointment reminders or whatever.
Exactly. Exactly. And then you say, well, now instead of doing email, people want text. And so now we got to get mobile phone numbers and whatever. And we can add to that system as we go and get whatever kind of information. And then it's just a matter, we're just keeping score, keeping track of what the front desk doing, making sure they do it right.
Right.
Let's go to a quality example for a minute. So what this group said, this was a group in the Southwest as well. And they were primary care, big hospital-owned group. And they said, hey, what we want to know is show us all the women that are age 50 to 74. We've seen them in the past 36 months. They haven't had a mammogram in the last 12 months that we know about. This is patient care thing. Let's just make sure that we're taking care of them. And whether you end up in some ACO environment or pay for performance or some kind of quality, something kind of environment, this is the kind of thing that's going to matter down the road, is can you track quality issues and then report back on them? Let me give you an example. This is from a dermatology practice. And what we did was we wanted to track no-shows. The y-axis, the one going vertically, is the percentage of no-shows. So every line is another 2%. The x-axis, what we decided to look at was how long is it between the day the appointment was scheduled and the actual day of the appointment. So if I call in today and I can't get in for 2 weeks, well, then it's 14 days on my x-axis of how long it takes to get in. And the interesting thing, if you look at in light blue there, it's a bit hard to see, but just below 6% is the overall no-show rate. But watch how that rate doubles if you can't get into this practice in 2, maybe 3 days. What they're going to do is they're going to make an appointment. They're going to call another dermatologist and try to get in. And so it became critically important for these folks to say, how do I get in? How do I get more patients through my practice? How can I respond to this? Because, they're dermatology. So number one, you might lose a patient visit, but you might also lose a cosmetic patient. You might also lose a procedure. You might lose a long-term relationship. Dang it, we want these patients in the door. And so what they did is they said, we're going to do everything we can to try to expedite the process of filling slots, getting mid-levels involved, eligibility and benefits, all the things that go into trying to get somebody in tomorrow. And last summer, they broke the record and got over 250 add-in appointments in a week. And the way they define an add-in appointment, Mike, is 3 days. If you call, we can get you in 3 days. That's good enough for us based on this chart. That's good enough for us to not lose the patient.
Mm-hmm.
And it's, and so it's not just reports, it's really acting on them. And one of the things they do to act is this is a SQL Server reporting services email. And what this practice does is say, dang it, this is their focus. It is their focus. Mm-hmm. So every 15 minutes, there's an email that comes out and says, did anybody cancel an appointment? Did anybody cancel an appointment? Okay, who is it? Where is it? How can we get people in? And this goes to several different people. It goes to the triage people. It goes to nurses. It goes to people in the billing office so that we can try to fill these slots immediately as fast as we possibly can. And that's how they got 250 add-in appointments in a week. And there may be 10, 12 providers. It's not a huge practice, and they're getting a ton of these add-ins because of that kind of data.
Wow.
Let's go back and talk about the 3 models for a second and wrap up. This is the old way. Mike was talking about the way we're all used to doing it. Dump it to Excel, clean it up, and run it. And it just takes too dang long. The other challenge is if you don't have the report you need, if the data you need is not in a canned report, you're out of luck. This dump to Excel thing doesn't work because there's nothing to dump.
Mm-hmm.
Model 2 says, no, we're going to go straight to the source. We're going to go to SQL Server where the data is stored. And again, far and away, The easiest way to do this is to own your own data. To not have to have it out in the cloud and say, Mother, may I, and try to get, access, but to own your data and get to SQL Server and then automate the process of Excel spreadsheets for analysis and automate the process of web pages and dashboards so that you can see what you want to see when you want to see it and get the accountability we've been talking about for the whole webinar. One more example, and then I'll go back to you, Mike. This is a group that back in early 2014, I mean, the date's on there, February 2014, the concern was it's good size practice. 30 docs, about that many, again, mid-levels, big practice with lots of pre-authorizations. And every day was drama in the pre-auth department. I mean, it's just every day is a crisis, every day is an emergency. And so we said, all right, we're going to understand this thing, and we're going to report on it, and we're going to measure it. When progress is measured, progress improves. And so the way this chart works is you got the number of cases on the y-axis going up the top, and then the number of days until this procedure appointment happens is on the x-axis. So day 1 is today. That means there's still a couple of appointments today or procedures today that haven't been pre-authed. And the way it works is the yellow color, the gold color, is pre-auths that aren't started, and the blue are pre-auths that have been started. We don't have a response back from the payer yet. So you can see there is huge drama. We've got 35 procedures tomorrow where we haven't started the pre-auth. This same report, this is a daily email that comes to the pre-authorization department and their manager and the manager above that. This was an issue. Same report 30 days later. Remember
just because they had the data.
Just because we had the data, the drama goes away. I mean, is there still, stuff that gets scheduled for tomorrow? We got a pre-auth? Yes, there is. But we can see it, and with that visibility and the data, now look how much more blue there is, compared to before and after, right? Look how much more blue and how far out that yellow is from 30 days of owning your data and seeing the reports and that kind of thing.
Yeah, it's key. I mean, owning your data, that's the thing. I'll say to some practices, well, we ought to be looking at this. Oh, we have that. Well, you do where? Oh, it's on this report. The problem with that is that sometimes there's data that's not on the report, or the report that the PM system or the software company put together just isn't in the format that you would really like to have it. And that's why I get really excited about this, because if we can get that data and get in there and grab it, we can create the report we need that'll be more helpful to practice and help them see some of the things that you pointed out here today, Nate.
Well, thank you. The one thing I want to say before I close is, if you've never seen pivot tables are a great way to get started managing data. Even if you don't have the SQL Server and you got to dump and clean and you got to start up Model 1 and start from start from square one. Pivot tables are a great way to analyze a ton of data. We've talked in the society about them a couple of times, and we got, like Mike says, once you've seen them, it's hard to go back. If you haven't seen them, that's a link to my website. There are 470 some free videos available on the website. They're typically 4 or 5 minutes a piece. They just show you a little piece of how to use Excel in a medical practice and kind of get started with business intelligence. Start thinking about custom reports. Start thinking about how to use your data. And that's a great way to keep going. With that, Mike, I'll go back to you and wrap up.
Very good, Nate. Well, first of all, thank you. That was just an unbelievable presentation, and helpful for me to see again and talk with you about it. So I'll tell you this. If you're watching this webinar, if I sent this to you and you think, boy, I would really like to do this, give me a call. You can reach me at 616-949-9030, extension 12. We'd be happy to talk to you more about this. And between looking at your practice, working with Nate, seeing if we can get this information the way that you want it, that's the goal. We'd be happy to help you. Nate, thanks so much again for coming on board, and we'll talk to you soon. And Nate, just a question. If we come up with some other video or something that we'd like to show a practice, or maybe we take a practice and find something else, you willing to come back on and do this again?
For sure. I think there's a bunch of different, I mean, you get me talking about reports all day long, but I think the one thing I'd say is, it's one thing to run reports. The other great thing about some of the SQL Server stuff is you can send copies of those reports to Mike and his team. If you got your trusted financial advisors that know the rest of your practice, they know the tax situation, they know the financial situation, they know where the loans are, they know where the money is, they know all this stuff. Now you can send them one more piece of the puzzle, so that the tax planning and the business planning, all that stuff makes a whole lot more sense when you involve them in the lifeblood of the practice, your data.
You bet. Thanks so much, Nate. With that, everybody have a great day and go out there and practice on purpose.